On y va.
Let's make a start. Now, I hesitate about the kind of tone to set for this debate. The good and the bad, I thought. Nicolas REVEL, who is in charge of review, agreed to answer the criticism of the other participants. So the subject is tragic. There are two terms given our healthcare system. Lots of people envy this healthcare system. Loss of luck and two-speed healthcare. I think that that's where we are today. Now, I'm not a judge, but this is just to encourage the debate between our three guests. Nicolas REVEL, representing our administration in all of its splendor, in a universe where we've lost our traditional landmarks. So he is very good at being diplomatic. You'll see how good he is at this. But will it be enough given our other representatives of the healthcare system? So we've got somebody who may be seen to come from the capitalistic system, but he says that's not true. So that's Jean-Luc BELINGARD. Then we have Catherine Estampes, who's in charge of General Electric Healthcare Europe. It's a worldwide company. We'll see whether she sees France as a Gaul village that's trying to impose its rules elsewhere. Jean-Luc BELINGARD, representing the healthcare industry from the Mérieux Institut. So we had our Prime Minister who was very friendly with the industry last year. Now, what about our asterisks? Jean-Noël ALBERTINI, brilliant professor of cardiovascular surgery. He is of worldwide renown. He's a genius. And will he find the solutions to the problem of France with its healthcare system that is perhaps supposed to be industrialized? Now, let's look at the slide from the Ipsos survey. What are the biggest innovations for healthcare in the next 10 years? Look at the results. For medicine, 67%, equipment, 63%, DMP, 57%, online appointments, 43%, connected objects, 18%, and augmented human beings, 17%. I was very surprised at these results, to be quite frank. Nicolas REVEL, you are probably very satisfied given who you represent. I was actually surprised as well. I wasn't expecting these results, and yet at the same time, I think it's quite fair to consider that the sharing of health information, the ability given to patients to be in charge of their information, is clearly an enabler for the improvement of healthcare and the ability of the system to provide better healthcare. And I think those surveyed have understood that. I think things will take a while to set up. Yes, absolutely. But when you look at the countries around us, we're not especially behind because there are no DMPs all over the place. So shared medical records. You know, we're not seeing this widespread in countries around us and in France because we've seized this subject again. What about what's in the pipeline? I think we started off in 2004 talking about this. It's a question of governance. In 2016, we came back to it. There was a lot of distrust about who should be in charge, whether it should be the health insurance system. Anyway, we've worked on the subject again. We haven't finished working on it, but we started again looking into this subject about a year ago, and we've convinced 7 million insured people to open up a shared medical record. So that's almost 100,000 every week. But instead of just talking about this medical record, the main thing is to feed data into it. And when you look at healthcare centers, practices, nursing homes, this is where medical records will be deployed. In 2021, we want all of the population to have a shared medical record. And this is something that we need to strive for. So we need to have a medical record that includes structured data, because if the record has structured data, it can then be a basic brick that will feed into all kinds of digital services and products and innovation. Yes, thank you. I've noticed that you compare us with other foreign countries. Later on, we'll have some other comparisons. Jean-Luc BELINGARD. I'll continue to talk about medicine. This is good. We need to encourage this idea. Now, I'm very surprised by several things given the discussion. First of all, the slide itself. I'm going to be rather brutal. It seems strangely out of fashion, because this distinction between medications and devices, that's not future medicine. Future medicine is an integrated approach to healthcare. Yes, but in the next 10 years, drugs will play an important role. Yes, absolutely, but only as part of an integrated healthcare approach. And as we're talking about governance, we need to talk about governance in relation to this integrated approach, not just in relation to drugs. Now, the integrated approach is very important. And if we don't have it, everything will crumble. I'm counting on you to correct that situation. Now, material. General Electric is very happy and rubbing its hands with glee. Yes. So the pink side of the answer is that personally, I'm quite happy to see that medical devices are almost shoulder to shoulder with other items in the survey. And the context is also important. It's a context where our customers, our healthcare stakeholders, have huge pressures in terms of cost, in terms of reimbursements, in terms of increasing access to healthcare. And all of this means that we have to focus on the creation of capacity, efficiency, integrated medicine, which means in vitro, in vivo data. So we're going to see innovation in the next 5 to 10 years, and it will focus on using healthcare data, including the shared medical record. So connected objects. So you are an example of that. It's your credo. Yes, absolutely. Now, concerning connected objects and digital objects, I think this is something that's being developed. Everybody is seeing this. Could you speak a little bit louder? Sorry. So, the development of connected objects, of digital healthcare, this is something that we believe will have a big impact on patient management in the future. So everybody's happy, including Guy Valencien. You can see that the score has improved, and that's why his book has become a bestseller, and I advise you to read it. Now, so records, online appointments, there are subjects that we will be able to debate. Let's start with Catherine ESTRAMPES. When you're a world leader in terms of the supply of equipment, production of transmission and distribution of energy, a maker of locomotives and airplanes, what is the role of healthcare? Well, GE Healthcare represents 25% of the revenue at worldwide level. GE Aviation is the second biggest business in the company. And it's an industry that is growing everywhere in the world for all of the reasons that we've heard this morning. So it's a critical industry. But the role of France on that market, it's very small. Is it enough for you? You're saying that France is not very good at innovation in Europe. Well, France, for GE Healthcare. Well, let me give you some background information very quickly. GE Healthcare has its roots in France. We bought Thomson CGR in 1987. Today, we've got the French market represents 25% of our revenue in Europe, but we've got 3,000 employees on the site in Buc, near Versailles, which is our European site, 600 development engineers, 100 million euros a year allocated to research and development in Versailles, and 90% of our production exported to foreign countries. So you're going very quickly. I'm taking notes. So you're not discouraged by the French administration? And what about the American administration? You're not discouraged to fight with the French administration? There are two answers here, very honest answers. The first is that for us, France is an extremely critical market. It's the second European market. It represents 25% of our revenue, and we've got an excellent healthcare system in France. I've been able to compare it to others in other countries and the United States. We've got some excellent teams, and we've made some great progress in terms of healthcare stakeholders. In terms of innovation, it's also a very important country for us. There are two aspects here. There's what works today and what we can improve. What works today? For example, we've got research credit, tax credit, and what other French agencies are doing. They're helping with innovation. There are some very concrete subjects being addressed. If you take oncology, cancerology, we've developed Pristina. That was in 2017. It's a product. It's a system for mammograms that we developed with other French organizations. And we're talking about 14 million in terms of investment, thanks to agencies, for a product that is being exported mainly abroad, 90% abroad. So we're working on a project for massively investing in artificial intelligence with several governmental agencies. So Nicolas REVEL is feeling very happy about what you're saying. So we need to move on to other things, otherwise the auditorium will be emptied. Now, if you want to interrupt, feel free. So once everything's said, what else is there to be said? I'm going to tell you what's not working, says Catherine. Now, I'm sure that you are disappointed with some things. So what about MRI? Yes, that's about simplification, flexibility, and agility. For example, if we want to develop an MRI sequence in France, it takes 18 months in France for negotiation. So 18 months between the different governmental agencies. It takes 18 months, or local agencies. In other countries in Europe, it's 6 to 8 months. So that's something that we've really got to improve on. So we'll hear from our colleagues and our director. So equipment, that's concrete information that we're hearing. I'm not going to say that France needs to make effort when it comes to certain procedural times. Other countries have managed to reach certain targets that we haven't. But I mustn't say that. Now, there are legal subjects that are managed by multiple agencies. I don't know whether it's the general agency landscape, but if you look at the averages that each agency has to manage procedures quickly, obviously there is progress to be made. And then you have agreements between agencies that are important, yes. So I've said that. Now, the second point, but I don't want to be too long about this, is that it's normal that there be time for collecting information and assessing the situation. I think, we need to have more comfortable processing times, but, these are subjects that also are linked to price negotiations. And there are other questions. For example, do we have any innovations or technologies or healthcare products that are supposed to be innovative that are coming along with the right kind of clinical trials, with the ability to carry out proper assessments of the innovations? And then sometimes there's this negotiating period that we have to have. And then there's the type of financial request. So we're comparing with other European countries. What's the blocking point, the stumbling block in France most of all? If I may just say something. Yesterday, we talked about the use of Article 51 for organizational innovation. Is there a scenario where we might imagine that this article might be used for the assessment of new pricing, set prices, in the study of the relevance of the introduction of new technologies, so that we have the right kind of technology for the right patient at the right time and in the right place, and with the aim of having medical efficacy and something that's cost effective. You've very well summarized what we have in Article 51. Article 51, we have to position it in relation to other objectives. So there's the innovation subject and the credit that can be given to companies so that they can develop their products and carry out clinical trials. In the finance law, we've widened the procedures to include other organizations. We've got a clinical trial that can be accelerated, and we're really focused on products and devices. And Article 51 should only come into play once the technology, product, or device is part of a healthcare process. And that's why we have the article. And that's why we've agreed to three projects that really correspond to those criteria. Jean-Luc BELINGARD, yes, all of that's well and good. But I think we have to reposition this kind of discussion in the context and the challenges relating to that context. This duration, so you will agree that sometimes it's above and off standard in terms of European standards. What is the state of health in France? Why have we got better healthcare in France when we have these durations? Perhaps one explains the other. I don't have the impression that we're treating patients better in Germany than in France. So I'm just bringing up a very important point. We have to appreciate this notion of duration in the context of added value to the healthcare system. That's the first point. The second point is that it's like we're in a kind of there's a paradigm here. We've got competition. France is perhaps losing its strength because things are going so quickly around us. Now, a reproach that can be made, the analysis that we make, is that we have to put things in their context. Context is that of international competition, very strong competition, which is making us lose our ranking, and in terms of France as a major healthcare player. Now, for devices, I realize that we are behind in terms of durations seen elsewhere. But when it comes to products and drugs, this is not the case. We have a system in France, and I think we can all agree. We've got the ATUs that allow us to enter the market. We have different phases. We can anticipate what we're doing. Thanks to the Commission, we've got free pricing. This is a system that is fairly powerful because increasingly we're having requests for ATUs that we've now widened to different indications. So I like to be transparent about this. I think the deadlines, the processing periods are long, but I think we need to be nuanced when we talk about medication, drugs. This phase is often criticized. When we're at the end of long durations, there is co-responsibility, don't forget.
Okay, we'll go back to drugs in a minute. Do you have any group negotiations at the European level, or does each country have its own rules? No, each country has its own rules. If I can just add something here with respect to what we were just saying and what you were saying, I think there's an enormous opportunity for organizational innovation. And we were talking about medical deserts yesterday, problems with the emergency wards. And I have personal experience with this. There's a richness of analysis of operational data in the French hospitals. It's enormous. A program has been developed called Commun Center. It's like a control tower in an airport that manages in real time all of the operational data in a hospital to improve patient flow, etc. So it's a command center. I have an example in the U.S. at Johns Hopkins. They had a huge problem with access and management to the emergency wards. It's a university hospital that works in a network. We've been working with them for 4 years now. It's one of the 8 centers we've been working with. After 4 years, they reduced their waiting time in the emergency ward by 25%. They increased their bed capacity by 25% without adding any beds. And if you, with respect to these medical deserts, they increased the receiving patients from other states by 65%. So I would like us to start thinking about this in France. Okay, let's go to the topic of drugs. I can say that in France, people are really laughing about us sometimes in other countries for diabetes and anti-cancer medication. People say that there are lost opportunities. Can you explain this, Jean-Luc? Well, let me just, I hear what Mr. Revel is saying, but what we have here with these temporary usage authorizations, these ATUs, yes, there is a mechanism which, from design, can allow early access to a drug. But then we have to look at the effectiveness of things. Today, you have a considerable proportion of drug companies that don't try to get one of these French ATUs or temporary authorizations because it's too complicated. So the problem of our country is not the design of the tool, it's the actual implementation, operational implementation of the tool. Okay, we'll come back to this. I discovered with stupefaction that OXIS and the PLFSS don't work together. OXIS would be the music, and the PLFSS should be the execution, as the president of the LEM said. Can you confirm that there's really no bridge between the two? Well, I'm surprised by your definition of things. Well, we can settle this during the break together. OXIS is the Strategic Council, which is a tool which supports the legitimacy of our companies as public health actors. We forget often that different companies in the drug sector are healthcare players and not just suppliers. Often we're treated as simple suppliers, but we're true, genuine stakeholders in public health care. And so, yes, maybe this is how we perceive things, but I think we should hear from the French health insurance representative as well. So the OXIS is the recognition of the legitimacy of our companies as public health actors. There's one objective for this strategic council. The OXIS has an objective, which is to work on the governance of healthcare companies and welcome them on the national territories. So the OXIS has set itself an objective, and I'm delighted that it's not combined with the PLFSS. The objective of the OXIS is to work on regulations to ensure that it stops being a weight that slows down the effectiveness of treatment. So the Prime Minister said it was innovative in terms of method and also in terms of piloting bodies in 2019. Do you agree with that? Yes, absolutely. And I have experienced this all year. Let's look at the promises. Guarantee to rapid access to innovation, 180 days maximum deadline. Where are we on those deadlines? Well, let me give you. Now, upstream of market access, not everything is perfect. Before market access, first of all, you have the clinical studies. There's no market access without clinical studies. and the procedures from the CSIS, which has led to the reorganization of the ANSM and the resources, has been productive in terms of deadlines, but we're still late because of the CPPs. Apparently, we have 530 days on average access to market. Well, that's without the clinical studies. Now, the CSIS has contributed to ensure that the ANSM was reformed, and then the French Health Authority was reformed. Well, let me give you some figures. It used to be at 80 days, and now it's back down to 45 days, so that's improvement. That's access to market in Europe. But what are the results today? Today, we're in a much better position. We're working on this. No. When companies bring in therapeutic innovation, we don't consider them as simple suppliers, certainly not. And when I was preparing this, people told me the figures were wrong. If you take the clinical phase, but that is a prerequisite to enter the market, we agree. If you have a very positive clinical trial, then we can say the time starts then, the counter starts then. When we arrive at this Transparency Commission, at the HAS, and then it arrives at the CEPS, then there are negotiations and a formal agreement and publication in the official journal. It takes about 207 days for a new drug or a new device. And so the phase between the time it arrives, the processing, is about 70 days on average. So it's a process that takes about 7 months in total. That's an average. And yes, everybody has in mind some applications that lasted much longer or that were never arrived at fruition. But why do we have some of these long, complicated applications? Well, you were talking about these temporary authorizations, these ATUs. Well, when I arrived at the French health insurance, we were using lots of ATUs. The LEM said there's something that's wonderful that France has with respect to other European countries, which is these temporary authorizations. Now, why are people taking a negative view of the ATUs now? Because we modified the rule for negotiating prices when it comes out of the ATU. So up until now, when you negotiated a price at the end of the ATU, the retroactiveness was only. Now it's been retroactive for the net price. So the perception of the ATU is a bit different today. So it's not totally illegitimate when you look at the fact that the companies, everything, we're asking them to separate what we call the face price from the net price. So I'm a bit technical here, but it's an average. The CEPS will update it in its next report. That's the average deadline, the average lead time. And the longest lead times, as I said, often these are price demands that we believe are very high, too high, even versus the assessment of the reality of the innovation. When the ATU expires, we have 25% of the products whose definitive clinical study said that the medical service rendered was either zero or low or moderate. So 25%. And then we have price demands that objectively appear to us to be very high. We carried out a study over 20 years of anti-cancer products arriving on the market, 20 years. And we saw that the price per year gained went from 15,000 euros to 175,000 euros per year of life gained. That's the reality of these new innovations. So we do manage solidarity systems in France. Sometimes we do have to negotiate, and we have to be tough. So when you hear a rumor, when we hear a rumor and a public debate, and we hear a rumor, that usually means that there is a problem. So Jean-Luc will represent some of these discontented people. So is this why we're running out? Because we have some of the highest prices or lowest prices? No, well, I'm not talking about the long negotiations that involve certain products. So, Jean-Luc, yes, this is a very animated debate. Now, to answer all of this, indeed, we can always refer to statistics that represent a certain statistical reality. But here, we're talking about public health. In public health, we want to make sure that the innovations reach their destination to serve the patients. And I can tell you today that there are certain products that exist with considerable added value that are sold all over the world and not in France. I don't have to mention any statistics to do this. So, if you will, there is a problem of the complexity of our ATU system. The concept of this temporary authorization is good, but it's implementation that's not good. But the cost of 175 versus 15,000, yes, that's what progress costs. Now we are entering therapeutic areas that are more and more sophisticated, that are more and more expensive. I'm not shocked by this price. I consider this as good news. So, if you will, the reality of things is that, and let me come back to the CSIS. The CSIS is trying to identify all of the regulations that are leading to the competitive availability. We have to look at this notion, competitive. These statistics should be going in the right direction, but if you look at the international level, we are completely out of phase in France. So I would like to recognize the fact that in France, they created this dialogue body for to optimize the regulations. We've been working on this for a year, and we're going to make progress. So the HAS said that we often have favorable opinions. It's price negotiation that takes a long time. So it's clear, not necessarily collective. Well, but that's not false. I think the HAS, the French Health Authority, does a good job. We saw that the lead times are under control. And yes, these negotiating lead times are what I indicated. Yes, beyond the averages, yes, there are some applications and negotiations that take a long time. But when we have these price demands where we have to assess it as SMR5, and this means that there's no improvement in the medical service rendered, and we're being asked to raise the price, this is a tough negotiation, and it takes a long time. It takes a long time. Just a quick word. I'm happy that Mr. REVEL referred to the SMR5. We have a system that has a rationale of assessment which is a bit academic, scholarly. The world is changing. The evolution of therapeutic tools are completely being revolutionized. We haven't heard about a reform of the assessment. But that is the future. That's the third promise of the CSIS in July. So where are we? We know that in France we have a terrible problem of expertise and experts. Yes, we have a difficult expertise issue, and yes, I know you're not happy if I say that the experts that we have don't seem to be at the same level as the experts that we meet in real life. Well, I don't know what allows you to say that. Yes, I can give you some very precise examples. Well, I think we found the right balance between the fact that you need experts who know the subject well, and if you want the expert assessment to be independent, there are a lot of experts of high quality, and they don't have necessarily conflicts of interest. But, well, the problem of the experts is simple. There aren't enough, and they haven't evolved in their adaptation to the world that's changing. So today, indeed, the system is completely blocked by this expertise resource, which is necessary because it completes the life of the ANSM, but it doesn't work well. What about the German system? It says the drug comes out with a price that is the average European price, and then the laboratory will reimburse the difference if the price is different. Could we do that in France? Well, we have a system where the products that we believe are the most innovative, SMR 3, 2, and 1. We have a European guaranteed price. But this, we use the public price, the sales price for this. And among the pharmaceutical companies, they're asking us increasingly to negotiate on the net price, on the discounts, which are non-public and not known. But the German system would allow us to start the real-life studies right away that everyone is waiting for, and you wouldn't have to do them afterwards. Yes, I agree, but then, of course, we have a system that is the ATU, the temporary authorization system, which doesn't, it works pretty well, actually. If you look at the number of requests and the number of ATUs issued in 2018, we have had a record number. So when you increase 50% a base of 1, that's not difficult to increase. So we cannot say that the ATU temporary authorization system doesn't deserve a bit of attention to be optimized. I really think it can be optimized. Well, we're running out of time. I have a little, there's a sentence in the final report by the CSIS. All of these promises, provided that we return to reasonable growth. Well, what do politicians mean with this type of sentence? You can always invoke the problem of growth. Well, again, we're leaving the scope of our conversation. There's a very important topic, which is the regulatory environment. That is what the CSIS is in charge of. The consistency between the management of healthcare expenses and the reality of how the CSIS works is a major issue. And we have to work on this. I'm just saying that even if the new Social Security financing law with the reductions in prices announced and all sorts of other economic measures may seem orthogonal, the CSIS is a reality that works. It's an interface with the French state. It's an interface for dialogue and construction with the French state. And I'm not pessimistic about the relevance of the existence of the CSIS in France with the people who support us honestly and seriously. So you're a happy president of the CSIS, but you had dinner with the French president. No, it was July 8th. Okay, I had dinner with him. And you said, did you come out with the same feeling of that they would be meeting their promises? No, the CSIS meeting with the president of the French Republic did bear fruit because the 3 ministers were present, and we set 9 priorities to improve our regulatory standards in France. Okay, apparently everything's going very well. Well, to close this chapter, our leaders want to support the dynamics of research and for industry. Have you perceived this? Well, I participated in several meetings of the CSIS, and I definitely see an improvement in terms of how they're taking into account the demands from industry. There's still... I wanted to come back to what you said in your introduction, is that we're going towards an integrated precision medicine with in vitro, in vivo, and digital. And the technology, medical and digital technology industries should be more present around the table. Do you agree with me? Yes.
The work is going on. Well, I've had to answer a number of issues. It's not a question of good against evil. We absolutely need to work in the long run to optimize our operations. I think that this dialogue between the industry in the framework of the CSIS and public authorities, that's extremely interesting and important. And I must say that your job is not easy. Just before coming here, trade unionists held you as a hostage, so to speak, in an office. Yes. Well, anyway, let's focus on figures. I don't want to be unpleasant, but the figures that you provided include generical medicines. No, I checked my figures. These are not included. This remains to be seen. No, it does not remain to be seen. It's very clear. We have generical and non-generical. These figures are about non-generical. Well, that will be the subject of another roundtable. So you ask yourselves what Mr. Albertini is doing here. When I saw that subject matter, I thought maybe it was a little bit out of focus, but actually, you have your hands at it. I'm going to give you 3 names: Professor Carpentier, Professor Crébier, Professor Ménacher. I'm sure that you know all of them. They work in the same area as you. There are 3 surgeons, 3 inventors, and you will be joining the trio soon. I believe that's very kind of you. These people are people that I truly admire. I'm not there yet. Well, I'm a journalist, and I knew them when they were younger, and I can tell you that you will be like them. Now, it took you 20 years to become aware of your potential. Yes, it was a slow process, a progressive process. I worked in clinical research for 10 years or so with whatever means we had at that time. Then I wanted to formalize some form of collaboration with some engineers. I got in touch with engineers of the École des Mines in Saint-Etienne. So far, so good. But then you had to create a company. Yes, it became more complicated then because I've never been trained for that. So when you really have to get started, it's not easy. Well, just getting there was something you're thanks to Claude Allègre, when he was a minister, he passed a new law, which means that you can now run a department in a hospital and a company. That's pretty new, somehow. Yes, that's true. Thanks to that legislation, an employee, a public staff member can take part to the creation of a company and take part of his or her time in this. So you are a head of department 12 hours a day. You are a business leader 12 hours a day, and that makes a perfect day, 24 hours working day. Yes, that's true. When you work on half-time in the hospital, you work 12 hours per shift. Why did you not get in touch with General Electric so as to get more means? Yes, we met, and he works with us now. Cinderella. No, that's true. There were 2 steps. In the first step, we didn't know each other, and we were still working in the lab. And when we created the company, we went to see some industrialists, a number of them, and G opened her doors. We will have to warn you, your driver, that you are going to be a little bit late, but now you are an industry man. What were your relations with the health authorities? Did they support you at all? Well, if you're referring to the hospital administration, it was rather easy. Well, yes, okay, but I had in mind some heads of departments. Well, we did not interact all that much. Are you interested in that type of profile, that type of people? Yes. Why don't you do any fundamental research? What's your product? It's a software of digital simulation for cardiovascular surgery. Are you still at a step where you still encounter some problems and sometimes you regret not having just stick to surgery? Well, we've experienced some problems, but as time goes by, things are settling down, and works rather well, but we've had some issues in the past. Well, we'll try and make sure that since you're here, both of you, let's hope that it will bear fruit. In fact, this theme is more important. The idea is that the future will be made with ecosystems that will bring together SMEs, major companies, hospitals. All actors will have to operate together. We will have to conclude now. I know it went very fast. What would you like to say in conclusion? Well, what I just said, the hope for the future with those new ecosystems. Jean-Noël, now in France, we are able to innovate and to carry out some research and innovation in the framework of medical systems and in the digital area as well. I think we have huge opportunities to seize. We must improve our capacity to bring some value with these innovations. Jean-Noël, as a conclusion, well, the upcoming environment is amazing. It's wonderful with technological innovation. Now the question will be, what governance will we need to accompany this major shift? Well, we are a great country for public health, and the governance that we have will soon belong to the past. So we will have to work together on a collaborative governance. Otherwise, our country will lose its ranking in the area of public health. But we know that public health is an element in society which has a very high value. What efforts do you particularly deploy with your teams? Well, we think that it is very possible to innovate in our country. That's an important thing to recall. This being said, I think we have a potential for progress. This idea of co-construction does not shock me. I think it's the very ADN of what we do with the National Health Scheme. But there's not, on the one hand, actors who are innovating, and on the other hand, the administration who tries to slow them down. It's a little bit more nuanced and complicated than that. The word innovation has been mouthed, but it does not mean that it necessarily has to go through a process of innovation. Of course, we have to sort things out because we have quantities of innovations around. But there's also the issue of the price, fair price, and all states must pay attention to that parameter. And let's invent new models. As you can see, we are sharp on time, so time has come to thank you. It seemed a bit short, but it's what it takes to have a genuine debate. I'd like to thank Aurore Guy and the others at the CHAM organization. And let's praise Junior Zero for his enthusiasm.